In the mid-20th century, across the United States, thousands of people entered hospitals suffering from depression, anxiety, schizophrenia, or psychological trauma. Some were violent, some were suicidal, others were simply considered difficult. At a time when psychiatric medicine had few effective treatments, many families felt they had nowhere left to turn. But one doctor claimed he had the answer. His name was Walter Jackson Freeman II. His treatment would eventually involve driving an instrument called an orbitoclast through the eye socket into the brain. He was not a neurosurgeon, yet he would become the most famous lobotomy doctor in American history. Freeman believed that severe mental illness could be treated by severing connections within the brain's frontal lobes. The procedure had originated in Europe during the 1930s, but in the United States, he transformed it into something far larger, something faster, something industrial. Before Freeman's method began to be used, the operation was far more intensive. Surgeons drilled small holes into the patient's skull, allowing instruments to enter the frontal lobes of the brain. Alcohol was sometimes injected into the tissue, or surgical tools used to sever neural connections directly. The procedure required an operating theatre, anesthesia, surgical staff, and significant time. But Walter Freeman wanted something simpler, a method that could be performed quickly inside overcrowded psychiatric hospitals filled with patients who doctors struggled to manage. So he developed what became known as the transorbital lobotomy. The patient is brought into a psychiatric hospital treatment room. The space is clinical, but not necessarily surgical. Bright overhead lights, metal instruments, doctors and attendants moving with practiced routine. There is likely little explanation given to the patient about what is going to happen. The patient is positioned on a bed or table. Electrodes are attached to either side of their head. Then comes the electric shock through the brain. The body stiffens violently during the induced seizure. The patient may drift in and out of awareness, disoriented, exhausted, unable to fully understand what is happening around them. The doctor lifts the upper eyelid. If conscious, the patient feels the cold, sharp pressure of the stainless steel spike of the orbitoclast pressing just above their eye. Then they may see or hear multiple soft strikes of a small steel hammer against the steel spike. The thin bone behind the eye gives way. The spike enters the frontal lobe of the brain. For some patients, this would be the defining moment of their life. Who they had been before the procedure could be very different from the person who returned. Then the spike was moved left to right to break connections between different parts of the frontal lobe. This was then repeated on the other side of the brain. The procedure itself may last only minutes. Some patients later appeared quieter. Others emerged confused, emotionally flattened, or profoundly changed. Conventional surgical anesthesia already existed, but using it required more staff, more equipment, and more time. The transorbital lobotomy was designed for speed and convenience. In fact, it was sometimes performed in doctors' offices instead of hospitals. On many occasions, patients were moved through the procedure one after another. Freeman believed he was helping people. He traveled across America promoting the procedure aggressively. Hospital administrators saw potential advantages. Mental institutions during the 1940s and 50s were overwhelmed, understaffed, chaotic. Some contained thousands of patients. Doctors had few medications available. Sedatives existed, barbiturates, paraldehyde. These heavy tranquilizers could quiet patients temporarily, but they could not treat the hallucinations and delusions many suffered from. But then, Freeman arrived, promising something extraordinary: a fast procedure, requiring minimal equipment that could calm difficult patients permanently. Inside the hospitals he visited, there were almost always several patients waiting for his procedure. Some patients agreed to it willingly. Others did not make the decision themselves. In many cases, consent came from families, institutions, or doctors. Freeman kept photographs, records, follow-up notes. He often described procedures as successful when patients became quieter, more compliant, less emotional. But many families described something very different. Some patients emerged unable to care for themselves. Others lost parts of their personality. Years later, some patients would describe the same feeling: not pain, not fear, but absence. As if parts of themselves had simply gone silent. Emotion was dulled. Initiative disappeared. People who once laughed, worked, or spoke energetically sometimes became passive and detached. Others suffered seizures, complications, or death. One of the most famous patients was Rosemary Kennedy, the sister of future President John F. Kennedy. Before the procedure, Rosemary could speak, socialize, read at a limited level, and participate in family life. But she was also described as emotionally volatile. Her father reportedly feared scandal and worried about behavior that might embarrass the politically ambitious Kennedy family. In 1941, at the age of 23, Rosemary underwent a lobotomy. During portions of the procedure, she was reportedly kept awake while doctors asked her questions. Freeman and surgeon James Watts continued cutting brain tissue until her speech became incoherent. Then they stopped. The outcome was catastrophic. After the operation, Rosemary struggled to walk, struggled to speak clearly. She lost much of her independence and spent most of the rest of her life institutionalized. At the height of Freeman's influence, the procedure continued expanding. Newspapers called lobotomy revolutionary. Some doctors viewed it as a breakthrough in psychiatry. Freeman himself became a public figure. He posed for cameras, gave interviews, demonstrated procedures before audiences of physicians. By the late 1940s, at its peak, thousands of lobotomies were being performed across the United States each year. But over time, serious criticism grew. Some physicians questioned Freeman's methods. Others were disturbed by the speed of the procedures and by the devastating outcomes many patients experienced. And then, psychiatry began to change. During the 1950s, new antipsychotic medications became available. For years, irreversible brain surgery had been presented as one of psychiatry's only answers. Then suddenly, there was another option. The most significant was the antipsychotic medication chlorpromazine, marketed in the United States as Thorazine. For the first time, many hospitals saw hallucinations and delusions reduced without surgery. And unlike lobotomy, the effects of medication were not permanent brain damage. As antipsychotic drugs spread, lobotomy rapidly declined. But Freeman continued performing operations for years. Then, in 1967, a patient died from a brain hemorrhage during one of his procedures. Afterward, Freeman was banned from operating. By then, he had participated in or overseen thousands of lobotomies. The exact number remains debated. But the consequences would echo for decades. Walter Freeman spent much of his later life revisiting former patients, corresponding with families, and defending his work. He acknowledged some failures, but he never fully abandoned his belief in lobotomy. To the end of his life, he largely continued believing that many patients had been helped. Today, Walter Freeman remains one of the most controversial figures in American medical history. To some, he represented a doctor attempting to solve an impossible problem during a time when psychiatry had few answers. To others, he became the symbol of medical ambition unchecked by caution. A man who transformed irreversible brain surgery into something routine. And perhaps the most disturbing part of the story is how ordinary it once seemed. Hospitals approved it, families consented to it. How many irreversible medical tragedies begin with someone believing they're doing good?